exciting the development.
All right. Thank you very much. Thanks for having me. I'm going to start things off with a little talk. I initially started off with just very generic talk about radiation oncology, but I guess the first thing about giving talks is you should always know your audience. And so I asked around a little bit and heard you guys are a pretty savvy group. I think you guys have a lot of people that come and talk with you. So I added in just some new things. I skipped over a lot of the basic stuff. We'll still hit a few of those things. It's a brief talk. We can certainly stop and talk about whatever you want to talk about, whether it's SBRT, whether it's, I heard an inquiry about proton therapy, advanced imaging like PSMA PET scans or fluciclovine PET scans, which are really new as well, and Dr. Sidana can talk about that as well. And then we'll hit on the multidisciplinary clinic at the end, which I think is really exciting for folks here in Cincinnati. So again, thanks for having me. Thanks for having us.
I'll turn the lights down a little bit.
Okay, sure. So, you know, radiation is an old...
Like that?
Yeah.
It's one of the oldest treatments for cancer, and a very old treatment for prostate cancer as well. And the basic tenets of radiation really haven't changed in 100 years. And what we do is we cause damage to tumor cells by destroying their ability to further divide, with the goal of minimizing damage to adjacent normal tissue to avoid side effects. So when it boils down to it, it's really just as simple as that. There's no magic behind radiation. There's no magic behind radiation. It's really just energy, and it's energy along the electromagnetic spectrum. So you have like your radio and TV waves here. Here's our visible light spectrum that our eyes can see. Here's ultraviolet light. And then as the energy goes up, you get into the X-rays. And this is what we use to treat prostate cancer with our linear accelerators. Protons are a whole different animal, totally different. It's a charged particle. These are uncharged photons. So this is just electromagnetic radiation, the same stuff that's coming out of the lights right now, just a much higher energy. So, and we can talk about protons. I didn't add any slides specifically about proton therapy, but we can certainly talk about it. This is what we do. So it's, again, when you boil it down, it's real simple. The tumor control probability is on this curve here, and the normal tissue complication probability is on this curve. And so if we wanted to cure 100% of cancers, we would be up here, but then if you draw a line straight down, you're looking at about 60% likelihood that you're going to cause some issue with that patient, side effect, significant side effect. So in general, we try to stay within the curve where we're curing about 90%. And again, that all depends on risk factors and so on and so forth. But this is what we shoot for, curing about 90% of cancers with about a 10% incidence of side effects. That's kind of the therapeutic ratio that we shoot for, really across all cancers. That's not just prostate cancer, it's all cancers. Sorry for the animation. So with radiation, there are a number of options, and I'm sure that can be overwhelming for patients. Brachytherapy is radiation seeds. EBRT is external beam radiation therapy. And the things I want to talk about today, because I think it's what's really new in radiation, is what we call hypofractionated external beam radiation therapy. We'll talk about stereotactic body radiation therapy, also known as cyberknife. Most people say cyberknife when they mean that. And then proton therapy, which again I didn't address specifically in this talk, but we can certainly talk about it. These are the machines that get the job done. So here's a standard linear accelerator. This does your conventional external beam irradiation therapy. This can also do SBRT or cyberknife-like treatments, but this is what the cyberknife actually looks like. So this is what the urology. How many people have been treated at the urology group or with the cyberknife? If they mind showing? No? Well, they would have seen this machine, and it's a fascinating piece of equipment. It's actually basically what's in the head of this machine here, mounted right here, on an automotive robot. So that's where they stole this technology from, an automotive robot. And then the couch, that's what the patient lays on, and that moves around as well. And so the machine kind of does a dance around the patient as it delivers the beam of radiation very precisely at the patient. So it's got a very catchy name. It's a fantastic piece of equipment, but this thing which most radiation centers across the country have, can do the exact same thing. It's just not called CyberKnife, it's called SBRT. Here's the Proton Therapy Center. This is actually a picture of our Proton Therapy Center here in Cincinnati. So this is up in Liberty Township. It's a joint venture between UC Health and Cincinnati Children's Hospital. We started treating patients, I think, in October of 16, I think. So we've been treating patients for a little over a year and a half now. We've been treating prostate cancer patients on this proton gantry. Yes, sir.
How much of that is children versus males, adult, prostate?
So it's a 4 gantry unit. Each one of these is a gantry or a room. One gantry is Children's Hospital, one gantry is UC Health. So it's half and half. So it's half Children's, half UC Health. There's a dedicated research gantry. That's the only dedicated research gantry in the world. A fully functional gantry that's specifically for research. No patients are treated on it. The only things treated on it are animals and cells in a petri dish. And then there's an empty vault. As patient volume expands, we can expand into another vault if need be. And whether that's the children's vault or an adult vault would just be based on volume. And then here's the brachytherapy seeds. So this is where radiation seeds actually go into the prostate, deliver the radiation from the inside out. This is my 30,000-foot view of prostate cancer. Dr. Sidana may disagree with me in some of this, but that's what makes our multidisciplinary clinic so important and so useful, because urologists and radiation oncologists often see things differently. We see it through a different lens. And when we sit down in the same room together, we can hash out those differences and really try to come to what we think is the best solution for the patient. Again, this is kind of where I just think through the options for patients. And so the spectrum of the disease is low-risk disease, which you guys all know very well, the high-risk disease over here, and then the different treatment options. And so I think for most guys who have low-risk disease, we recommend active surveillance, and that's probably the first step we should do. And then that kind of tapers off as the risk of the disease goes up. Prostatectomy, almost always an option for any risk of prostate cancer. Brachytherapy seeds by themselves, mainly limited to the low-risk and intermediate-risk disease. There are some people doing brachytherapy for high-risk disease. It's generally done with high-dose brachytherapy, not something that's offered here in Cincinnati as far as I know. William Beaumont Hospital up in outside Detroit in Royal Oak pioneered HDR brachytherapy and probably one of the world experts up there. External beam radiation therapy, again, very much like prostatectomy, has pretty much a role in any risk group. Hormonal therapy, really not introduced until you get up into the intermediate or high intermediate risk, and then once you get up into high risk, always included, particularly when we use radiation therapy. If you combine external beam and brachytherapy, that's meaning about half the course with external beam, and then you do what's called a brachytherapy boost. That's really limited, again, to the more high-risk disease, because it's really considered an escalation of care for therapy. So briefly hitting on SBRTs or CyberKnife. This is a really good treatment. I think it's not something that we have historically done at UC, but it's something that I'm intrigued with. In fact, like Memorial Sloan Kettering Cancer Center treats a ton of their patients with SBRT. So there are institutions around the country that have bought into this wholeheartedly and are doing a lot of SBRT. What is SBRT? SBRT is 5 or fewer treatments. So you get the entire course of the radiation treatment delivered in 5 treatments, generally over 2 weeks. Why have we not adopted SBRT or CyberKnife at UC? Mainly for the first point here. Currently the data is somewhat limited. The follow-up data for SBRT is relatively short because this is a newer modality. We've only started doing it in the past 10 to 15 years. And so I guess you would say we're just conservative. We're waiting to see what happens with the guys as it goes out. But thus far, what's published in the literature is the toxicity rates and the efficacy of the treatment is the exact same as conventional external beam radiation. So I think it's a very good treatment and actually biologically makes a lot of sense. So it's something that I may start to implement in my own practice. And this is something that is commonly done at the urology group with their cyberknife unit. Yes, sir.
Would you define that high dose rate up there, please?
It delivers a high dose. Yeah, so gray is how we measure radiation, and that's really like milligrams. So it's just a unit of measure that we measure radiation in. And a conventional course of radiation is 80 gray, 76 to 80 gray, delivered in 38 to 40 treatments. That's what we consider conventional. That's 7.5 to 8 weeks of radiation to the prostate. We're giving half of that dose, so it seems like less, but it's actually only in 5 treatments. So the dose per day is 8 gray per day, approximately 8 gray per day. So that's a very high dose of radiation per day, whereas the per day dose with those other regimens that I mentioned is only 2 gray. So you're giving a much more potent dose of radiation in a shorter period of time. So even though the dose is less, half as much, it's much more potent. Does that make sense?
It does. But define the term GY.
Gray.
That's the gray. So that's it's joules per kilogram. So and joules is a unit of energy, and then per mass, and then we just call that gray.
So typically they say that radiation is dose limited, right? So we can't expect to receive more than 80 gray without causing damage. And this is only 40 gray. So does that mean that you can do it twice?
No.
If you have to?
No, because again, the body, when you're giving 8 gray per day, that's very potent. So actually the concern is that this could even be more toxic than the 80 gray. That's why we have been reluctant to jump into this. But I'm going to show you something that helps ease that fear a little bit. Plus the data that we have published thus far, not us, but that people have published thus far, shows that the toxicity is the same. I would say that this is equivalent to 80 gray. It's just biologically, the cells see the 40 gray delivered in 5 treatments almost the exact same as 80 gray delivered in 40 treatments. Does that make sense? So they're biologically equivalent despite the fact that the dose is different.
Could I ask a question? What's the cost benefit? I mean, I'm not trying to be glib or anything, but I can see that it's short.
Yep.
But do you, and I don't know if those 3 categories, I didn't memorize the previous slide, but which of the 3 does this apply to? But what is the benefit? Do you expect a cure or a remission or what?
This is cure. This is curative treatment. And this is mainly for the guys in the low to intermediate risk or high intermediate risk. Some people are doing this for high risk disease as well. But this is kind of more for your most people would say for your lower tier or lower risk prostate cancers. You're not treating any of the lymph nodes in this setting, it's strictly just treating the prostate.
So this wouldn't apply to anybody who's metastasized?
Correct, unless you're doing what you're doing, which is you can also utilize this form of treatment on like a bone metastasis. So, and this is very precise treatment, and we do that at UC all the time. So we do the SBRT of metastatic lesions. So let's say it's spread to the spine or spread to the bone. We can target it with sub-millimeter accuracy and give a single dose of extremely high radiation and ablate all the cancer right in that spot.
And my doctor talks about quality of life. What do you expect the quality of life with this to be?
With this treatment in particular?
And do you perceive it, or can you just continue to walk around?
Yeah, no. Most guys, like almost all radiation treatment, when you're going through it, it's very well tolerated. And in fact, with this treatment, you have really no idea that it happened to you. The main risks with radiation are really kind of delayed or long term. That can happen years down the road. And again, that's why
cancer on top of my cancer, that's a joke.
And you can, but yeah. So no, if you got this 2 weeks of treatment, you could continue to work. I mean, it's very convenient for guys because it's 5 treatments instead of 40 treatments. So.
And you said that is available in Cincinnati?
Yes, the urology group does this right now.
And then how does Medicare feel about this?
It's covered. I mean, this is a standard treatment. This is on all guidelines. This is a standard treatment. It's not significantly cheaper for your insurance company because the rules or the billing for radiation oncology is just kind of wacky. But if you do this 5 treatments or less with these high doses, that's called SBRT. SBRT is reimbursed at a very, very, very high reimbursement rate. So it's financially lucrative for places to have SBRT or cytomorphic treatments. It's probably the reason why the urology group, who are urologists, they're surgeons, actually have the unit in their building, because this makes a lot of money. These things make a lot of money. It's a good treatment. I'm not knocking that, but finances rule the world. That's the way medicine is, to be honest.
But you said if the insurance is Medicare, it's covered.
Yeah, should be. I wouldn't see any reason why it's not. All the treatments that I mentioned today, including proton therapy, are covered if you're under Medicare. So this is a game-changing technology, I think, to really improve the safety profile for SBRT. And this is what's called the space OAR. So here, this is an MRI scan of the prostate. It's the prostate in the middle. This is the rectum. And so you can see that the interface between the prostate and the rectum is very close. They are basically intimately associated with each other. And so any dose you give to the prostate, the rectum gets 100% of that dose. That's where the long-term risk comes from. The main long-term risk with radiation are what's called radiation proctitis, which can lead to chronic rectal bleeding. It can lead to fistula formations, bowel obstructions, and these are all very bad things. Now, they're unlikely to happen, but if they do happen, they're bad. With this, the space OAR, it's done in a procedure suite. It's very much like the prostate biopsy, so an ultrasound probe goes into the rectum, and we put a needle through the perineum, which is the skin between the scrotum and the anus. We numb that area up, so this is done awake. There are some places that put you to sleep to do this, but we've been doing it awake. You numb up that skin, the perineum. You place the needle right into this space right here under ultrasound guidance, and then you inject this hydrogel spacer. It's a gel material. And it gives about a centimeter space between the rectum and the prostate, which allows you to give as much dose as you want to the prostate, and you would almost get 0 dose to the rectum. So this is a very powerful tool, and I would say anyone who is considering getting SBRT should really strongly consider having the space OAR, because it can protect the rectum. This lasts for about 6 months, and then the body just reabsorbs it, so it doesn't stay there forever. So this was just Medicare approved, meaning we can now bill for it, meaning that it's open to pretty much anyone with both Medicare and private insurance, January 1st. So this was a big development. Okay, the other new thing in radiation, moderately hypofractionated radiation therapy. So we are not blind to the fact that coming back and forth for radiation treatment 40 times is cumbersome, particularly if we have guys living an hour away. I mean, that's a lot of visits back and forth to the radiation center. So we realize that that's a huge burden and a significant commitment on the patient's behalf. So this has really been pioneered out of Europe, because Europe is bundled care, and they have single payer systems, and so radiation is all billed on the number of treatments that you give. And so in Europe, it would make sense to decrease the number of treatments, because that's a lower overall financial burden for the healthcare system, which is the government, which at the end of the day is the taxpayers. And so they started doing fewer and fewer treatments. And so what they do, very similar to the SBRT, you drop the total, you drop the number of treatments, but you slightly increase the dose per day. And so this is what I call the Goldilocks approach. So it's about half as many treatments, 20 to 28 treatments, to get the whole course of the external radiation in. And the data that we have thus far shows equal efficacy and toxicity. So I have almost uniformly moved to this approach in my practice. I'm very, very, very rarely bringing patients back 40 times. I have selected the 28 treatment regimen. It's been my personal experience that the 28 fraction regimen or 28 treatment regimen is slightly better tolerated than the 20 treatments, but that's my own anecdotal experience. The data would say that they're all equivalent.
What is the treatment you're talking about there? Is that the SBRT? or
No, this
something?
is external beam radiation, so just general what you would get if you just chose radiation treatment, external radiation treatment on the same machine where you would get 40 treatments, but this is 20 to 28 treatments. The technique is almost the exact same. It's just a slightly higher dose per day, fewer number of treatments. Does that make sense? Yes.
The doctors from Christ Hospital talked, and I think they're saying they're like, they don't really push 5 treatments, they're like 14 treatments or something like that. So is it kind of a sliding scale by the provider, or?
It is a little bit. That's why I kind of call this my Goldilocks. So I think 40 treatments is probably too much, and just I mean, it's a perfectly fine treatment. It's a standard treatment, but it's inconvenient. And the SBRT treatment, again, I have my reluctance to jump into that realm. So this, in my opinion, is that kind of happy medium between the two. The 20 and 28 treatments has the most data behind it, the most robust data behind it. I'm not aware of a 14 treatment regimen personally. Here is the data. So this is this was the Prophet study, 1,200 men. So that's a huge study in prostate cancer, and this was done in Europe. So here is the 20 treatment regimen. Here, this is the one that I do. This regimen right here. So also had a ton of guys in it. Wait, sorry. This is the one that I do, the RTOG regimen, and 1,200 guys. So this is the 70 gram and 28 treatments. That's the one that I do right there. Okay. Touching on the multidisciplinary clinic, real quick. Does anyone have questions about different radiation modalities before I get into this?
Yeah, I do. So for all of us to understand, there's EBRT, SBRT, there's other BRTs as well. What really is the difference? I mean, is there something, because when you go to the CyberKnife website, they say, oh, it's super precise and blah, blah, blah. Is it really more precise than that EBRT machine you have?
Absolutely not.
Really?
Yeah. These machines nowadays are sub-millimeter accuracy. So the couch top on this machine is every bit as good as the couch top on that machine. It has 6 degrees of freedom, meaning it can roll the patient in any way it wants. The onboard imaging of this machine probably exceeds what is done here. We can get a poor man's CAT scan right on this machine, so we can line you up with sub-millimeter accuracy every single day. And so these type of machines have really caught up with this. And these are very much niche machines, so they really only can do the SBRT. You cannot do this 40 fraction treatment or 40 treatments with this machine. So while these became rapidly popular, again because they bill at a very high rate, they became rapidly popular, and don't get me wrong, it's a fantastic machine. These have caught up, and you can do everything else on these machines. So,
Can you talk a little bit more about patient prep? And
Yeah.
you know, I know in some places they put you in some kind of a special box or some kind of, you know, and to assure that you minimize patient movement and so on and so forth. Can you talk a little bit about that?
Yeah, so what I generally recommend for patients is that they come with a full bladder and empty rectum as best as possible. Full bladder limits the amount of bladder being exposed to the radiation treatment, so if you can come and you feel like you kind of have to urinate, that's the best time to get your radiation treatment. And so, in fact, we have bottles of water for guys when they come in. If they don't feel like they quite have to urinate yet, they drink a bottle of water. We have them sit until they feel like they have to urinate. If you have an empty rectum, it decreases the amount of rectum that we're also treating. So I know those are 2 hard things to ask someone to do, but most guys get into the routine of it pretty well. In terms of how they lay down on the table, you lay down on the table, there's a beanbag type device that goes on the legs or underneath the legs. We suck the air out of it, and then that forms a cast basically for you, and your legs then end up in the same position every day for treatment. You have marks that are put on your skin, and those marks are set by laser coordinates in the room itself. So then every day you come in, we line the laser coordinates up with the marks on your skin. That gets you probably within a centimeter or so accuracy, and then you do the onboard imaging, and that's where we can then shift you to get to sub-millimeter accuracy.
Okay, so you line it up with CT. In other words, how does that work? Tell us a little about that.
Yep. I don't know if you can quite make it out. Do you see this little arm here and that arm there? Those come out, and they basically kind of look like this. They come out, and then the machine rotates around the patient, much like a CAT scan does, and you get a CAT scan. So
is it like real time? Are you
yep,
actually?
we do it right before the treatment. Yep. And the proton gantry can do the exact same thing. Here are the X-ray detectors on each side of the proton gantry. So this was one of the first proton gantries in the world to have what we call cone beam CT.
Okay. One last quick question about radio. Do you have any follow-up data about levels of toxicity? Do you guys record that? Can you tell us a little
Sure,
about
I took out the slides that had toxicity. There is a fantastic article in the New England Journal of Medicine. It was published, I think, 2016, about 2 years ago. And it was the Europeans are pretty good about doing big studies in prostate cancer. Big studies in prostate cancer do not happen in the United States just because of bias and any number of issues. In Europe, they're much better about that. And whether it's just the European attitude towards medicine as well, that it's a single payer type system, so they're more apt to go on to studies and so on and so forth. But they did a study that flipped a coin 3 ways for all guys with prostate cancer. A third of them got surgery, a third of them got radiation, external beam radiation, up to the 40-ish fractions or so, and a third got active surveillance and then were treated at any sign of progression. So the outcomes with that were that surgery and radiation and active surveillance actually have similar survival. And so that really wasn't that groundbreaking. We knew that already, but what they did was very, very robust patient questionnaires for toxicity. And what you see is that the vast majority of guys are happy with the decision they make, regardless if they choose radiation or if they choose surgery. The side effect profile is different. So from that study, we see that there's more urinary side effects, particularly in the short term with surgery, so more urinary incontinence with the surgery. Now, radiation is not free of urinary side effects. You get more burning with urination going more frequently. But the guys who had surgery had more dissatisfaction with their urinary symptoms in the short term, but then they tend to come back together so that all the groups, again, meet up at the very end. Sexual dysfunction, slightly greater in the surgery group as well. So the likelihood that you would have erectile dysfunction, slightly greater in the surgery group. Bowel side effects were more common in the radiation group. So that was the one side effect that was significantly worse in the radiation group. If you utilize the space OAR, which they didn't have, I mean, this technology is pretty new, one would think that you would decrease the bowel side effect. So the rare bad side effects with radiation are similar to the rare bad side effects of surgery. They happen in 5% or so or less of patients. So the vast majority of guys are happy with their treatment. So I'd say, if you choose to treat your prostate cancer one way or another, whether that's surgery, whether that's radiation, be 100% confident in that decision, that it's the right decision for you, because the data says that you will be happy with that outcome, and that your cancer control outcomes will be very similar regardless of the approach that you take. So I always tell guys, make the decision that you feel best with in your heart, because it's the right decision for you.
And to follow up, the Barrett Cancer Center, the radiation group there, do your data track these other studies, I guess they're
In terms of our
studies?
In terms of our own outcomes?
Yeah.
Yeah. Have we looked at our data in the past recently? Probably not. I mean, I think Bill Barrett probably has the greatest number of patients who've been treated with radiation at the Barrett Center. He keeps a log of his patients, and he knows very well how they do, but he has not reported on that recently. But anecdotally, yes, of course, it tracks along with all the other what's reported in the literature. The actual way to deliver the radiation treatment, the technique, those sorts of things, relatively straightforward and pretty standard across the country in terms of how it's done. So I think the outcomes that you see in a clinical trial should translate well to any radiation center that you go to, any reputable radiation center. I don't really have any reservations about any place here in Cincinnati. I think everyone does a pretty good job. Other questions before I move on to the multidisciplinary clinic? Yeah.
Do you have any information on how proton beam radiation compares with side effects compares with EBRT?
So, great question. The second question I've had about proton therapy, so I apologize for not including it in the slide set. So, proton therapy is a very powerful tool. Protons are different than in all these techniques. Protons, the beam comes out of the gantry right here, and we actually tell it exactly how far to go into the patient. So it enters usually through one side, and then it treats the prostate, and there's no exit dose. With a photon unit, there's probably about 90% of the dose exits out the other side. We get away with that by rotating the treatment unit around the patient so that we spread that low dose out, but where all the beams intersect, that gives a very high dose of radiation. With the proton unit, only 2 beams of radiation, one from one side, one from the other side, no exit dose. So you get much less low dose radiation to the bladder as well as the rectum and some of the other soft tissue. The high dose radiation to the rectum is almost about the same though. Because again, without this sort of device, you kind of have to treat right there anyways. So the risk of serious side effects, which is all related to the high dose, the risk of serious side effects is almost the same. And in fact, every study that we've tried to do to date that's compared conventional photon radiation to proton therapy has essentially showed that the outcomes and the side effects are about the same. The big difference is the low dose of radiation. So in conventional photon radiation, all of this tissue is getting a moderate dose of radiation. In proton therapy, there's no radiation exposure to any of this tissue here or any of this tissue back here. It all comes from one side and then the other side. So the big thing is that it will probably reduce the likelihood that you have chronic, long-term, many, many years down the road side effects, 10, 20, 30 years down the road. So I think in young guys, it's really beneficial. So, you know, our young guys, 50-year-old, 40-year-olds that are diagnosed with prostate cancer, I think those are the guys that are really, really beneficial for proton therapy because that low-dose radiation exposure, that's carcinogenic. And that can increase the risk that you develop a secondary cancer caused by the radiation treatment. So the thought is that you'll have less risk of a secondary cancer caused by the radiation treatment, which is already low to begin with, usually about 1% or so. But that could be reduced even lower with the proton therapy. But we have no data to prove that because that takes 10 to 20 years to develop, and proton therapy has really only been used widely for the past 10 years or so.
And that's the reason why children's is that.
Oh, yeah, kids should probably only be treated with proton therapy because, yeah, we put the radiation exactly where we want it, and yes, we do really well in pediatric cancer. We cure, the vast majority of patients, and so those guys, the kids, hopefully have normal life expectancies, and yes, so you're significantly reducing the likelihood that they would experience toxicities. Yep.
I had proton beam treatment about 9 years ago in Bloomington, Indiana.
Yep.
And no side effects at the time of treatment of any kind, and none so far. It'd be nine years ago in a week or two. I can't say right now whether it was low or higher dose. So
I bet they were using probably pretty standard, about 76 to 80 gray. I think that's what they were doing at the time.
yeah, that's my recollection.
Probably
that
30,
resonates
38 treatments or so.
Yeah.
Yeah.
My PSA was 8.7 before I started. It got down to a nadir of 0.24. That was 9 years ago. Now it's just short of 1. That's probably pretty slow progression, I would say. Now Loma Linda's been doing it for probably about 20 years.
Right, so they were one of the pioneers since the early 90s. So they were one of the very first to start treating patients. Lawrence Berkeley Laboratory is kind of where proton therapy came from. They started treating patients as early as like the 1950s and 1960s for certain indications, not really prostate cancer. But Loma Linda was the very first proton therapy center in the country to be specifically dedicated to patient treatment. In fact, the unit you were treated on in IU in Bloomington was a research gantry, just very much like Lawrence Berkeley Laboratory. So IU actually built that for a physics research, a cyclotron. And then they said, well, if you treat patients on this, we can make a lot more money, treating cancer patients with this than you can with than doing physics research. So, and plus IU Health wanted a proton therapy unit. So they retrofitted it to treat proton therapy patients. Because of that retrofit, it was enormously expensive. They were losing, so they got to the point where they were starting to lose money on the order of millions of dollars a year. And that's why they closed it down. It just was too hard to keep retrofitting what was initially just a physics research laboratory to a patient treatment unit. Yeah. Yeah.
From the point of view of a patient, I haven't heard you say anything that's a disadvantage of the proton involved.
I don't think there is any disadvantage. So if I was going to get radiation treatment for my prostate and my insurance covered it, I'd probably get proton therapy. That's what I would do. One disadvantage, if I just may add, one disadvantage of the proton therapy, specifically the way that we do it, we currently use a rectal balloon to immobilize the prostate. Did you have a rectal balloon? So you know first-hand experience what that's like. That's a device that's inserted into the rectum every single day for treatment. It's inflated with saline, and so it's a bit of an uncomfortable procedure. It's obviously a slightly invasive procedure. Every day something's put into the rectum. We're doing that currently. The hope is that we may be able to get away with that or get away from that in the future, but that's the way we are currently doing it. So that is a disadvantage.
How many days?
Right now we're doing kind of the 36 to 40 treatments on the proton therapy unit. We have treated a few patients with the 20 or 28 treatments as well.
You mentioned rectal problems with the proton. Why not use a spacer or proton?
You can.
Okay, so that might minimize that one aspect of it.
It's an extra procedure. It's an invasive procedure, but yeah, there. So if I was having my prostate radiated, I would have it irradiated with proton therapy, and I would have a rectal. Sorry, guys. I would have a rectal spacer. But did it fall off? Or turned off? Sorry, I think I made it.
The idea of radiation.
What's that? Yeah.
I didn't like the idea of radiation.
Yeah, right.
It's an if, you know.
Can everyone hear me okay without the microphone? Okay. So, but I'm not trying to oversell proton therapy, okay? So it's a very powerful tool. We have yet to prove that it's better. So if you're considering conventional external beam radiation therapy, there's all the data in the world that says it's just as good as the proton treatment. I would never pay for proton treatment out of pocket. So even if I was a believer in the proton treatment, I wouldn't, sell my house or take out a second mortgage on my house to pay for the proton treatment.
But if you were Warren Buffett, you would.
Yeah, if I had the means to do it, or if my insurance covered it, I would get the proton therapy.
I thought I just heard a gentleman up there say he had it 9 years ago, and he said no side effects ever since.
You can find guys who have had conventional external beam radiation therapy 9 years ago that would say the same thing. But yeah, it's a very, don't get me wrong, it's an awesome tool. It's the latest and greatest technology. I think the vast majority of proton therapy centers around the country treat a lot of prostate cancer on them because prostate cancer, number one, is common, and number two, it's almost tailor-made for it. I mean, the target is very easy. We come in from 2 beams from each side. It's a beautiful treatment. It really is. Dr. Sidana, you had a comment?
No, I said you were saying if I was going to get radiation, because I think you're probably going to get surgery. It's so often.
This is why we work so well together in the multidisciplinary clinic. Any other questions about proton therapy before I get to the multidisciplinary clinic?
With respect to the
Yes.
slide that shows the 3 stages, this is again only good for the first 2 stages, right?
Not necessarily.
And by the way, can you make this slideshow available through an email? Is this a PowerPoint
Yeah.
that could be sent out to us later?
Sure.
It's online if you want to look at it.
I'm sorry?
The slideshow's online if you want to look at it.
I can't hear you.
He said the slideshow is online. Is it available through the group? Okay, one caveat to that. I put this together. This is not endorsed by any governing body or anything like that. So this is Dr. Tim Struve's personal opinion on prostate cancer. So just take that for us. Okay, any other questions? Yes? Sir?
I had my first biopsy last May,
Okay.
and I'm an Gleason of 6.
Uh-huh.
And the surgeon wanted me to have another one about now,
Yep.
with an appointment to see him in May. But I'm in the upper range of low risk, and I'm fearful that the biopsy itself can irritate the prostate and increase the PSA. And I'm choosing not to get that biopsy he wants me to do about now, but get a PSA prior to going in May. I don't know about
Maybe I'll turf this one to Dr. Sidana because he may be able to better answer that. But I think the regimen that your doctor has in place for you is very appropriate and standard. I think when you go into active surveillance, generally another biopsy is done a year later. But there may be other things to consider, like an MRI scan. I don't know if Dr. Sidana, if you have anything to add to that.
So did you ever have an MRI?
Yes, I did a couple of months ago that showed no lesions.
So if you had an MRI which did not show a lesion, so your odds of having a clinically significant cancer, which is 7 or higher, is around 4% from like several studies by several groups. So if a good radiologist read your MRI, your odds, completely negative MRI, your odds of having something significant is low. So this is something, as a urologist, our active surveillance protocols have been defined rigorously with what Hopkins started 15 years ago. Back then, we were treating prostate cancer by surgery for everybody, or radiation for everybody. There was no active surveillance. This was a new thing which started 15, 20 years ago. So it was a very rigorous protocol where we did biopsy every year. Now with MRI and our understanding of prostate cancer has improved so much in the last 15 years that I think I would feel comfortable not getting a biopsy if MRI is completely negative and your prior biopsy showed only Gleason 6. Okay. There's always 4 or 5% chance that you might have a small component of Gleason 7, but would it change your survival? I doubt it would. And if it's gonna be growing in size, then eventually you'll find it 2-3 years down the line anyways, and you'll still be in that window of cure. Okay, you won't miss that window.
I suggest that's a good segue into
To
this
the multidisciplinary, correct? Yeah,
Why don't we
definitely.
let Dr. Struve talk about that, and then we can ask questions afterwards.
All right.
Okay, perfect segue. Actually, this was really at the leadership of Dr. Sidana. So he's been a huge addition to UC and to the urology department at UC. So we started the multidisciplinary clinic for prostate cancer patients. We started a couple months ago. I think we're into our 4th month or so doing this. We meet once, I'll get into that, but we meet once a month on 3rd Friday of the month right now. And the multidisciplinary clinic is made up of myself, Dr. Sidana, and Dr. Sana Verma. And then the goal or the hope is that we would rotate in other urologists or radiation oncologists as well. I'll tell you that Dr. Verma is world renowned actually for prostate MRI. So we're certainly very fortunate to have her reading our prostate MRIs on our patients. And again, she's really one of the leaders in the field.
She's one of our favorite people around here.
Yeah, has she come through? Okay, all right. So you guys, I don't need to toot her horn anymore. It's she's fantastic. So she comes to the meetings. We review everyone's pathology. We review everyone's MRI scan with her, and then we try to come to a consensus opinion. So someone such as yourself that's maybe had an MRI done outside, or your urologist is outside the UC system, you can come to this clinic, we would obtain your MRI scan, we'd review your MRI scan, and make sure that Dr. Verma agrees with your outside radiologist that, we don't see any lesion on there, and then Dr. Sidana and myself would see you and say, well, we think active surveillance is a great regimen for you. And maybe we can replace your repeated biopsies every year with MRI scans. I mean, that's much less invasive.
One thing I wanted to add, so when I was looking for jobs after my fellowship at NIH, and you guys might have heard Dr. Peter Pinto and Barry Struve. So they told me, like, if you have to work with a GU radiologist, Dr. Verma would be the top 5 in the world to work with in terms of GU radiologists. So it's such a respect coming from Dr. Turkey, who I just like worship, and he said that to me. So in our multidisciplinary clinic, I think Dr. Verma being there has added a lot. Like, I did MRI research, I looked at thousands of MRI, but even I sometimes do not pull up MRI in patient visit, just there isn't much time. But this clinic lets us see an MRI, review an MRI, and that definitely helps in treatment planning. Like, it helps me in telling patients. So me and Dr. Struve were talking about radiation. So I go and tell patients, yes, your one nerve will be spared because there's no cancer nearby, even though you have high-risk disease. Traditionally, you know, when you have Gleason 8, 9, 10, you get wide excision bilateral nerves. Those are not spared, but now we can, and that's what Dr. Verma being in that clinic and having an MRI imaging. Secondly, when we know the location of lesion, we can offer them other treatments. We are not limited to surgery or radiation. We can offer the focal treatments also, and I think that's the advantage of having 3 minds looking at those things without any bias.
I remember the terminology they use as, and the results, I said, no suspicious lesion. So I don't know if there was a lesion at all.
Yeah, no suspicious lesion means negative. But again, this is prostate MRI, if you see, has been around only for 10, 12 years. Like in the way we know it today, has been around only for 10, 12 years. And a lot of radiologists who did residency even 5 years ago never saw a single prostate MRI in their residency, right? And if you talk to Dr. Turkey and Dr. Verma, it's a very specialized skill. So, and like we were at NIH and we would get MRIs from GW or Georgetown, and they would be read completely negative, and Dr. Turkey would find a Pirates 4 lesion in that. And then there would be time when they read a Pirates 5 lesion, and Turkey would say no significant lesions. So it's a really, really challenging field. So I don't know who your radiologist was, and I think that's the only thing which you need to keep in mind. If you think the radiologist is very well respected, and if you read no suspicious lesions, then the odds of an MRI to miss something is relatively low.
So
ProScan, I went to ProScan.
I think they have their scanner's fine, but you don't. We're not here to talk badly about any physician. I think the medical community within Cincinnati. I mean, we're very fortunate to have a fantastic medical community in Cincinnati, but I know personally that Dr. Verma is one of the best in the world, as Dr. Sidana has said. So we'd be happy to take a second look at your MRI scan. So that's no problem whatsoever. So I found out tonight that the urology group is actually starting their own multidisciplinary clinic. So this may be wrong. It's maybe not the only of its kind in Cincinnati, but I think that's great. I think more access to clinics like this is very important for patients. We would love to see you in our clinic, give you our opinion. This is the other point I was going to make to you. This is not to steal you away from your urologist. This is to give you a second opinion on your disease, to give you more information so you can make an informed decision. This is not to pull you into our system or anything like that. This is to be a service to the community.
I do want a second opinion. Should I tell my urologist I'm getting there, or is that not necessary?
You don't have to, but if you want to, that's totally fine as well. I brought some cards tonight
We'll
for.
give you numbers and
Yep.
cards. The other thing is, our aim from this clinic is not to treat. That's our activity. We do not tell patients to make that decision that they are. We actually tell them, think about it and make the decision, call your own urologist. So I get patients from Dr. Brack and Patel, and they go back to them. And I'm pretty sure Dr. Struve does the same thing. So far, I think I've treated only one patient from that clinic, and the reason was the patient chose focal therapy. and nobody else does focal. But this is not for treatment per se. You can choose your treatment wherever you want. This is just to get information and then pick your provider. So we also have like list of providers who treat from UC mostly, because we give referrals to Dr. Martin and Dr. Dawson.
I think I've discussed pretty much everything on here. So we meet from the noon to 1 o'clock hour with the group that we just discussed to review all the patients that we're going to see that afternoon. Each patient has an hour-long clinic spot where they see myself for 30 minutes and they see Dr. Sidana for 30 minutes as well.
Just one quick question. How long do you think it'll be before you get overloaded with patients?
Well, we can always expand the number of days that we do this, and so that would be. So those are good comments to have. So we're okay with that. Yeah.
Yeah, so when I heard about this group, which I think is a very important group to have, it was my impression that the patient was actually sitting in
On the discussion.
on the discussion,
Mm-hmm.
as opposed to just getting the results
Yeah.
from individual practitioners.
So I think that's a unique model. It is done. It's actually done in a couple places where tumor boards, a patient will actually come in and they are discussed amongst the group. I think not having the patient present gives us some freedom to really discuss critically maybe what's the best for that patient. I think sometimes when you have the patient present, you can hold back certain thoughts which may not be in the actual patient's benefit. So, Dr. Sidana may say, I want to do surgery on this patient, and I'd say, well, I don't think surgery is the right thing to do. And then I don't want you second guessing Dr. Sidana because I disagree with him right in front of you. We're having that discussion amongst ourselves so that we come to the patient with kind of a uniformed approach. And there are times when we say, actually, this person's a great candidate for surgery, this person's a great candidate for radiation. And then, in that case, the decision is left to the patient, and we give them the pros and cons of each approach. But we say, there's probably not one modality that's better than the other for you. The other thing that it can do, where do I see the value of the multidisciplinary clinic? It's a good opportunity for a second opinion. It's a one-stop shop. You see the urologist, you see the radiation oncologist on the same day. We can potentially expand treatment options, focal therapy. So that's something that Dr. Sidana has started to do at UC and is becoming more and more common across the country. He'll tell you that in Europe they do a ton of it. So, you may get a suggestion for focal therapy out of this. This multidisciplinary clinic where you possibly wouldn't have gotten that through your primary urologist. And then potential availability of clinical trials. Clinical trials, particularly for intact or definitive treatment for prostate cancer, are currently lacking both locally and nationally, but we do our best to try to keep protocols open for patients, and so potentially maybe UC would have a protocol available for patients. And then our ultimate goal, as Dr. Sidana has mentioned, is to really give you an unbiased opinion and to be a resource for the community. The goal is that you go back to your community provider. Yes, sir.
What is focal therapy?
Great question.
So, focal therapy means, so traditionally the way we were treating prostate cancer is we were doing either the radical surgery where we remove entire prostate, or we would do radiation therapy where we destroy the entire prostate. But if you look up the radical prostatic specimens, most of the specimens have less than 10% prostate cancer, right? So 90% of our prostate is benign, despite that the entire prostate gets removed. Now if you think kidney cancer, we don't remove entire kidney, we do just remove the tumor, we do partial nephrectomy. When you have a colon cancer, you remove the segment of colon with cancer, we don't remove the entire colon. Brain, right? You can't remove the entire brain just because there's a small tumor. Breast, females in this era would not agree to do a radical mastectomy for a small tumor, right? That's a lumpectomy for the same reason. Only for prostate, we were removing entire prostate, right? And people were not even complaining because it happens in 70-year-old males, and it's not breast cancer. But with now MRI in the last 10 years, we can localize prostate cancer. Before MRI, we could not localize prostate cancer. We did not know where the cancer is. It is on left side, right side. If it's anterior, it's posterior, it's apex, mid, base, how big it is, what grade it is. We did not know that. Now with MRI, we can pinpoint to 95% accuracy. Yeah, 5% of the time we will miss clinically significant cancer, and you might be that unfortunate person, but in 95% of the time we will know exactly where the cancer is, how big it is, and if it's feasible to be destroyed by itself, leaving the rest of the prostate alone. So that's what focal therapy, the basis of focal therapy is. So like I did a case this morning. The gentleman had tumor in the right mid of the gland between internal, which is called transitional zone, and outer, which is called peripheral zone of prostate. 1.2 centimeter lesion. So with MRI, it allows us, with the fusion capability, to draw a border around the lesion. So destroy the lesion and a 1 centimeter healthy margin around it. But we still left that gentleman with 80% of his prostate. So 80% of his prostate was left alone because it was benign. So his morbidity from that procedure will be like 10 times less than surgery. He won't have any incontinence because his sphincter is not damaged. He did not have any cuts on his body, and he has a Foley catheter which comes out tomorrow morning. And then we kept him overnight because of some social issues, but he could have potentially gone home today after 2 hours. It's a completely outpatient surgery, and your oncological outcome is same, especially for cancer, where so far we have not even established that treating patient helps, right? Even though the studies are not very high caliber, like PIVOT trial, it's not a very high quality study, but that shows that if you treat prostate cancer patient and not treat prostate cancer patient, they're going to live the same age, right? But in US, it's never going to happen that we would not treat prostate cancer patients. Patient gets anxious. Nobody wants to take that legal responsibility of not treating an aggressive prostate cancer. So something like this, I think it's perfect treatment. It's not overkill. It's not under treatment, and that's the rationale behind focal therapy. But you have to be in that small 10% of the patients who will become eligible for this. So that's why I think multidisciplinary clinic with Dr. Verma in there, it's really beneficial because we can spend 20 minutes looking at an MRI. In my clinic, even though I get MRI in every single patient, I don't spend 20 minutes looking at MRI. A lot of time, I don't spend any minute looking at MRI, and it goes by the report. And with report, you can't tell if patient is going to be focal candidate or not. And that's when Dr. Verma is there and we are doing together, we can figure out that you can destroy that part of the prostate without damaging rectum and without damaging urethra. And this will be focal candidate.
So you use the radiation?
Currently we use freezing, cryoablation. Freezing. And the reason we use freezing is, this is reimbursed by every insurance, Medicare, every insurance. You don't have to pay $25,000 to get it done. It's like regular surgery.
Is that the laser, Dr. Solomon? The laser is what you said?
Yeah, but they charge you $25,000 cash.
But the outcome from the cryotherapy versus the
same.
laser is the same?
Same,
right?
exactly. It's exactly the same. Cryoablation has been around for a long time. Until recently, actually I would say until even last year or 2 years ago, we did not have a really good way to target with cryoablation, accurately target with cryoablation, and that's where the laser came into the picture. Laser, when I was in NIH, we used to do laser even 3 years ago, because laser you could do while patient is still in MRI. So we used to use this neurosurgical instrument because they used to do this accurate brain tumor destruction using laser in MRI room per se. So we use their technology to start treating prostate cancer while the patient is in MRI. Now, with the help of fusion machines and the newer platform Cummings, which allow us not to just do biopsy, but also do intervention with MRI information, we can do that stuff in OR, operating room, regular operating room. Once we get into the operating room, we can use any energy source to destroy the tumor. It could be laser, it could be cryoablation, it could be HIFU, or it could be water vaporization. There are multiple other treatment modalities, and they're going to keep coming. And we're going to try to get more treatment modalities. Currently, we have cryoablation because insurance pays for it, and it does not cost you a penny more than regular treatment.
So why do they not cover laser ablation versus cryoablation?
Cryoablation had evidence for the last 30-40 years, and when we do cryoablation, we bill as like a prostate cryoablation.
Okay.
Insurance doesn't ask us how much of prostate you destroyed, not because of that. You get billed as prostate cryoablation, which is a procedure which has been established for 30-40 years. While focal laser ablation, we didn't have any laser procedure for prostate, like to destroy cancer. We have laser procedure for TURP and everything else, but not to destroy cancer. So there's no code for that. So this was more like an experimental procedure, and it had decent efficacy in hands of experts. But
I
now,
noticed that Cleveland Clinic does focal laser.
exactly. So, but focal laser is gonna die. Like we stopped doing that even in NIH, right? The focal laser, the only reason was back then we did not have a way to accurately target outside of MRI machine. You cannot do cryo in an MRI machine room because every equipment is metallic, and you can't get metal in MRI. While the laser instruments, you were using it, was everything non-metallic, MRI compatible. But when you do focal laser ablation in MRI suite, it takes 4 or 5 hours. While a focal cryo case in operating room takes 2 hours. And you achieve the same outcome. And you get, like, have regular insurance pay for it. So you're not dependent upon somebody who's willing to pay $25,000 to do it.
So you're using still the MRI.
MRI
to
is
pinpoint the lesion.
Exactly.
Using the
but not in the MRI machine. So we get an MRI before.
Okay.
So if somebody has gotten fusion biopsy here, so it's the same concept. So you get an MRI, and then there are different vendors. One is Philips and they have a machine called Uranap. One is Iten, and they have a machine called Artemis. So MRI information is transferred to these machines, and then what these machines do is they superimpose the MRI information on a regular ultrasound in the rectum. So put ultrasound in the rectum, this machine combines MRI information which was done before with the ultrasound in the rectum, and all the suspicious areas gets superimposed on that ultrasound. Okay? So when the surgeon moves ultrasound in, out, up, down in your rectum, the machine moves with it. There's a GPS system which combines both images. You're getting ultrasound image live in the operating room. MRI images moves with it as you move the ultrasound because now they're combined with each other.
So your confidence level that you're actually hitting the lesion.
Exactly. And there's been data around for like years now. That's why we stopped doing MRI guided biopsy, right? We do fusion biopsies now. Back then, even when Dr. Verma started doing this MRI, she would do biopsies in MRI room because there was no machine which could use MRI information outside MRI. Now with these machines, we can use the MRI information with fusion technique, and it's been around for a while. The JAMA paper, if you have ever read, the Siddiqui JAMA paper on MRI fusion, that's that machine, Uranap. And UCLA group, NYU group, all these prostate groups, they have like Artemis machine. So these are the machines which would essentially help us utilize all the MRI data and target the lesion outside MRI. because doing anything in MRI room is very, very challenging and limited because you can't get any metal in that room.
Do you see that possibly as taking, for the low risk or intermediate risk of cancer? Do you see that?
Yeah, I think so. It's just like, so as a urologist, you have to adopt a very unbiased approach and you have to be really careful. So that I personally feel, there have been studies from Europe, they said around 50% of the patients with Gleason 7 would be eligible for focal therapy, like treatment destruction of just localized part of the prostate. We tried to do that at NIH. We had Gleason 7 cancer, and our numbers were really low, like really low, 20% or 25%. So either there's a difference between the European population and American population, either that's the case, or maybe Europeans did not look that carefully. We looked really carefully, so only 15 to 20% of the patients who are Gleason 7 will be eligible for focal therapy. But it's up to the urologist and the radiologist to sit together and identify a good candidate. You have to be a good candidate to get actually benefit out of this treatment. Otherwise, you're just making your ultimate surgery more difficult or making your radiation more complex down the line. It won't change anything in your survival. I don't think it will make you live any shorter just because you got focal therapy first. It just will, you'll still end up getting surgery 2 years down the line, but it's going to be a little more complex.
Now, is there an extra benefit from the cryo therapy? I heard that they can create some antigens that actually fight the cancer itself.
Yeah, that was initially a focus of my research. I have not been able to restart that at Cincinnati, but when I was at Hopkins, I spent 2 years studying the immune potentiating effects of cryoablation, and that's one reason that's one of my favorite energy delivery modality. You could choose anything. We're going to get HIFU in the next couple of months too, but for some patients I'll still choose cryo because first HIFU is going to be again $25,000, and I feel cryoablation has higher success rate in the field, and also because of immune potentiating. So what cryoablation does is it destroys the cells by something called coagulative necrosis. It's a fancy term. So when cells are dying, instead of dying a happy death, which is called apoptosis, they die an unhappy death. They are very irritable, inflamed. So there's a lot of structured things going on in there, a lot of inflammation, a lot of cytokines. All that stuff goes in that part of your prostate, which gets destroyed by freezing. So when that happens, our immune cells get attracted towards that area. They take up whatever is left of that cancer cell, which are called antigens, okay? And they express that marker. So there's a marker saying, I am cancer, okay? So they take up that marker, I am cancer, and they go back to other parts of your body. So your body now recognizes this marker, which was hidden in your prostate. Okay. So now your body reacts against that marker and kills those cells wherever they are. So the immune potentiating effects are more beneficial in a setting where you have advanced disease. So you destroy the cancer in your prostate and generate an immune response like Provenge does. So it's kind of Provenge by cryoablation. If you know what Provenge is an immune therapy against prostate cancer. Or Prostate, which is a vaccine. It's something similar. It's like autologous vaccine. You get created in your body itself. And that immune response goes in and find cancers, find prostate cancer cells in your body and kill them. So this concept has been around for now almost 50 years. Late in 1960s, there was a urologist who actually first found this. So what he was doing, he was freezing prostate in patients who have metastatic disease. So he was doing cryoablation. Back then it was whole gland cryoablation. So he was freezing prostates, and he realized in some of the patients he froze prostates, their metastatic disease disappeared. And then he repeated the treatments on the patient. He realized when he repeated treatments, the immune response got even more stronger and there was more disease regression. And he coined the term called cryoimmunotherapy. And that's the basis of this entire field. Since then, I think maybe there are more than 1,000 publications on this in animal models. So all of us know it works, but it's very, very weak and we need to find a way to strengthen it. So is everything else. Prostate works, very weak. Provenge works, but very weak. You know, all these things work to some degree, but they're weak. So far, we have not been able to establish how can we strengthen it enough and destroy prostate cancer altogether by immune response, like we have for melanoma or we have for kidney to some degree. We don't have that strong immune response for prostate yet. But I think it's just a combination of immunomodulators and something like cryoablation or prostate or provenge, which will give us that ultimately strong immune response.
I don't think I have any more slides.
I wanted to bring up one issue because this has been so much in the news lately. Like there was an article in the Journal of Clinical Oncology about this issue of to screen and not to screen. And you know, it's like it's raised kind of sort of the temperature level, I think, in the urological world. And I was wondering if you guys could address it because you know, obviously, you know, guys who come to you and they've been, you know, their PSA's gone up and they're, you know, they're very anxious and they go to the urologist, he wants to do a biopsy. This has been the traditional, and you know, so now people are starting to worry about doing biopsies because for one thing, the rate of infection is going up a little bit. And also it may not be necessary. There are other tools, okay? So there are tools like Select MDX, you know, 4K, there's different non-invasive tools that could be used to have to home in and see whether you really need a biopsy. So that's part of the big controversy. To not screen at all, to me, is crazy because, you know, cancer, prostate cancer doesn't kill most people, but it kills some people.
It's
So
30,000 people.
well, yeah, so I mean, you know, you want to, I think you want to screen, but what to do after you screen is the question, right? What to do after your PSA has gone up somewhat, then what? So,
And to some degree, one of my first project in US was we were trying to study the treatment decision making in young men with prostate cancer, and from that study I realized, and that's kind of a little bit motivation behind this clinic. In that study, more than 75% of young men said they want more information and they preferred. So there are three sorts of decision making in medicine. First, a doctor decides for you. Second is called shared decision making. You sit with a doctor and decide for yourself. Third is informed decision making. You make your own decision. So informed decision making is considered the best in medicine, like especially for something like prostate cancer, where nobody knows what's the best way to proceed forward, right? We know there are treatments and it takes care of cancer, but how much benefit we get, we don't know that. So that's why I think for something like prostate cancer, you have to have informed decision making, and that's where you can get your answer on PSA screening. You have a PSA, you get a biopsy. I think people should get biopsy if PSA is abnormal. And now it's your informed decision making. A doctor should tell you what this means, what your odds are. I had a cop came to my clinic, in a multidisciplinary clinic, 53-year-old Gleason 6 cancer, and he said, I live my life by avoiding all risks. And he would not give up on treatment. He said, no, I want treatment. It took me an hour to convince him to get active surveillance. He kept saying, if the red light malfunction, somebody calls me to direct traffic, I know I have to get out of there in 15 minutes, otherwise somebody will hit me, right? So that's how I lead my life. I avoid risk, kept going on for an hour. So I kept going on an hour, and ultimately he was convinced and he agreed to stay on active surveillance because I knew a single core after MRI guided biopsy in a 53-year-old who's really healthy it's probably not gonna be a problem. Yeah, it might be a problem 8 years from now, 10 years from now, and we can do prostatectomy then. But the advantage of prostate cancer is the window of cure is really long. You're not gonna miss that bus, most of the time, right? So there's a long time, and that's where I think informed decision making helps. Let patients make their own decision and they'll be happy with it. Ultimately, it's your happiness, right? Ultimately, you wanna avoid a regret. Even if you live 6 months long, if you avoid a regret, I think that's the purpose of treatment in prostate cancer.
Okay, so let me zoom in on this question about these non-invasive tests that are supposed to be before you make a decision.
So yeah, and they're really good tests. They're really promising. Okay, all these tests came out from retrospective review of data from one institute to another. The Cleveland Clinic one was, I think, Decipher. The Oncotypes Cleveland Clinic one came from Cleveland Clinic data. Then there's some came from University of Michigan data, right? So these are retrospective data analysis. So what they did, they had tissue from patients from like 20, 30 years. Now somebody in the lab found out that this marker relates with prostate cancer survival based on data entered 20, 30 years ago. And yeah, the data might be accurate. It's also possible data is not 100% accurate. And statistical tests, you can find significance in any test, right? People who do clinical research know finding significance is not that difficult when you have 30 things running in. So all these tests have 18 markers running against 18 things. One of them will be significant. And maybe down the line, one of these tests will be proven to be significant in a prospective setting and will make a difference. Currently, all these are just retrospective studies. It's not any more good than any low back clinical study saying, okay, my prostate cancer patients have 90% erectile function, right? You can say that. It's that kind of data.
I understand. So
You're talking prior to biopsy, so patients who have not had biopsy, but trying to determine if they have prostate cancer via a different mean. There's a urine test or peripheral blood biopsies.
PCA3 and Select MTX are the two urine tests, and then there's 4K, which is a blood test. Okay, so if you guys, all right, so what you want is prospective data, right? But if nobody's using these tests, they're never going to have prospective data. So when are you guys going to step up and give it a chance?
Some people use it. I feel in most institutions, I do not get any more information than what I get from MRI. I do not.
But MRI costs $1,200 or $2,000.
Yeah, and that's
the urine
completely valid
test costs
point.
maybe $100.
So my question is, how should I select my choice of test? Should I just flip? I know one test which works for me and which I have full confidence in, which has much more robust both prospective and retrospective data, versus a test which I get these reps come to my clinic almost every week, telling me do Select MDX, do 4K. Now there's another new test called Exosome DX, and there are like multiple tests at that stage. How do I pick my own test if none of them have data? All of them have a really high impact publication in a good basic research lab, but historically there's so many things. So things which work in basic lab, almost less than 1% of them actually translates into human beings. It does not work that way.
I agree with Dr. Sidana. I think that even if you get one of those tests and they're negative, but we still have a high suspicion that you have cancer, it didn't add anything. Whereas on the MRI scan, if we get a negative MRI scan, we feel very reassured that you probably don't have
And
cancer.
there's a prospective data, the PROMISE trial, right? You get an MRI, you save prostate biopsy 27% of the time. So yeah, it's an expensive test, but
I think, Doctor, one of the things I think you're talking around but haven't maybe addressed directly is the fact that I think the MRI, I think now you're talking a multiparametric 3T MRI, whereas some of the ones in the past were like a 135, right? So maybe you could talk about how that technology has, increased the ability to actually see the lesions that exist in the prostate over than what they were in the past, right?
So the newer data, if you see NIH paper for covering the last 3-4 year data, they have said that they missed prostate cancer 4% of the time with 3D multiparametric MRI as we know today exists. You know, back then 8 years ago we were using MR spectroscopy, we were using 1.5T MRI. With 3T MRI using DWI, DCE, and T2 weighted images, and somewhat reasonable radiologists, the odds of missing clinical significance 5%. Now, I know that data exists. I've looked up that data myself. I know there's a prospective trial from Europe with Dr. UCL, University College London, and these guys are really pioneers of focal therapy in MRI. They're really way ahead of us in US, right? They have shown with their promised data. Then there was some Italy group who did randomized control trial. They said, okay, you get MRI, you get regular biopsy. And they showed in their data it was 0%. None of the clinical significant cancer was found if MRI was negative and biopsy was negative. Okay, so now I have such a strong data, and now a rep comes to my clinic and it's one of the 8 tests. And they say it's going to cost only $300 to the patient to get this test done. Now I get that $300 test, I'll end up being there again, right? So I always talk to this reps, I'm happy to do this, give me first 50 tests free, and I'm happy to do this. But nobody gives me first 50 tests free. If they would give me first 50 tests, I'm not gonna pick a select techniques versus, because for me, all of them are equal. All of them have a good, strong, basic research publication behind it. I don't know how it's gonna pan out. While MRI, I know it pans out well. The other advantage which these tests don't offer, they'll tell me he's clinically significant cancer. Okay, he's clinically significant cancer. Now, if you're a 56-year-old, you have clinically significant cancer, would you like me to do a systematic biopsy? Right? First of all, if your clinically significant cancer is an area of the prostate where systematic biopsy needle doesn't go. For systematic biopsy, we sample less than 25% of your prostate, right? 75% of your prostate doesn't even get a needle in, okay? So this marker tells me you have clinically significant cancer. Now I go and sample only 25% of your prostate. And I say, oh, you're negative. This marker is wrong. Now, something is off here, right? Then I'll think, okay, this marker was positive. Your biopsy came back negative. Let's get an MRI. So you end up on MRI anyways. Or even if you have a clinically significant cancer on this marker, I biopsy, and you have clinically significant cancer on MRI, but now you're 56 and you have really good erections, you don't want surgery because you know surgery has side effects. Now what would I do? Let's get an MRI, right? Then I biopsy you, you have Gleason 9 cancer, very high risk cancer, but you still want to save your erections. And I said, okay, it's a little bit challenging, but maybe you have Gleason 9 in just one segment of your prostate on extreme left side, so I can save your right side now. What would I do next? Get an MRI. So there isn't a situation, so the only patients I do not get an MRI are where I know he's deconditioned, debilitated, medical morbidities, and I do not feel like he would be the best candidate of annual MRIs and biopsies every 2-3 years. It's too much for this guy to do. Or the guy is not motivated at all, or he just does not understand anything and doesn't want to go through that paradigm where he would get repeated MRI or repeated. So for those patients, I do not get MRI. But anybody who's somewhat educated, somewhat motivated, I do not see a reason, at least in my practice, where I can avoid MRI, so why spend extra $300?
Are you familiar with the companies in town that are doing MRIs for $400 or $500?
Yes, and I use them. So yeah, and we started using them because insurance was giving us a lot of tough time about MRI. It's really expensive in a hospital setting. Even though I would like Dr. Verma to take a look at it, MRI, Because it's also, there's two things about MRI. It's not just the machine, it's also the radiologist. This is a skill which general radiologist does not have. So if somebody's telling you that they can read MRI, prostate MRI, working with one of the two best radiologists of the era, like Dr. Verma and Dr. Turkway, and both of them have said the same thing. If somebody's telling you that they can read prostate MRI just because they did a radiology residency, they are probably not correct. You cannot learn prostate MRI by going to a workshop for 2 days. This is not that kind of skill. It's way more specialized skill. So if you can get that ProScan MRI read by Dr. Verma, we have done that in some of our patients just because insurance says it's so expensive to get it done and it's not indicated. Blue Cross Blue Shield, for example, gives the toughest time. They would not approve MRI for a lot of patients. So we offer this Blue Cross Blue Shield.
Okay.
So we tell our patients get it done at ProScan and pay out of pocket. It's $400 $500 and it's 1.5T, but their 1.5T is really good. It's really good. I was surprised to see how good theirs is. And then you just have to, I have to just request Dr. Verma to reread it, but other than that, it's okay.
I kind of got lost in all the examples you were giving. So I've got one basic question that is, I think the answer is no, but can an MRI be used as a substitute for a biopsy?
Yes.
Well, that's what he said.
It could be. It could be. In US, we have not reached that stage. But in Europe, yeah, it has already substituted. US, there are multiple reasons. First, insurance gives a lot of pushback for MRI. Okay, we cannot get MRI on all patients. For some reason, at UC it's a little bit easier. It's easier to get things done on patients. And this is our healthcare, right? It's easier to get things done on patients who are on financial assistance than patients who have good private insurance. Yeah.
It can tell you,
It's
the MRI can
easier.
tell you your Gleason score
MRI,
and also tell you the sort of topography of where the cancer is within the prostate.
it would not tell you a Gleason score, so that's the sad part about imaging yet. Maybe one day we'll have imaging which will tell us the Gleason score. MRI would not tell you Gleason score.
It's very good at avoiding repeat biopsies. So guys who have low risk prostate cancer, Gleason 6, instead of getting repeat biopsies every year, those are the guys you can actually monitor with MRI scan. And then you would biopsy again when you see a change on the MRI scan. So you can actually do imaging biopsies of them at yearly intervals to watch it instead of putting the needle in the prostate every year.
The other thing is MRI will avoid biopsy altogether. There are some surgeons who are really confident. They did not biopsy if MRI is negative. I personally have not reached that stage yet. Just started practice recently. But maybe 5 years down the, or maybe even less, if I see a negative MRI with Dr. Verma's read, I probably would not biopsy. But there are people who do that routinely. In Europe, that happens all the time. Dr. Emma Group UCL, if your MRI is negative, you don't get biopsy. Then your odds of dying of some other is way higher than 5% chance of missing clinical significant cancer with MRI.
How much do you have age factor into the decision? What if the guy's 80 years old versus 70 versus 60? Is that,
If you're 80 years old, yeah, you should not even think about prostate cancer unless you have bone mets or some other symptoms. But so age is a lot. Again, that's why these things are really important, and that's why it's really important for a prostate patient to talk about his disease with physicians for a good 45-50 minutes. This is not a disease like kidney cancer. My kidney cancer appointments are literally 15 minutes long because you have a cancer. The only treatment is it comes out, and this can kill. We know that. We've proven that, and there's no other treatment. So there's no discussion there. You just tell them this is the surgery, that's the side effects, that's what it's gonna be. Bladder cancer, no other treatment, comes out. Prostate cancer, first of all, we don't even know if the treatment is gonna be beneficial in you, right? We don't know. Yeah, in a 55 years old, I think the treatment will be beneficial. Even the PIVOT trial has some data showing it's helpful in patients who are less than 65 years old. But if you are 65, 66 year old, treatment might be beneficial and it should be done. But these are all like, I cannot say with that convincing argument like I do for kidney cancer or bladder cancer that you have to get treatment. So that's one thing. And then Gleason 6, we know now that there's no point in treating. 15 years ago, we don't know that. Is Gleason 7 also going to be like that 15 years from now? We don't know that. The data shows the mortality from Gleason 7 is 4 to 5% over 15 years, so not that high. But these are treated Gleason 7s. And then the data also shows that 8, 9, 10, regardless of how aggressively you treat, they do poorly. Okay. So there's a healthy doubt about if patient is going to benefit from the prostate cancer treatment. And that's why the screening age has been now reduced to 69 instead of 75, which was like 5-6 years ago. So we don't know how long do you have to live to benefit from prostate cancer treatment. I personally feel 15 years. That's what I use. If you're not going to live for 15 years, I don't even do biopsy. There are patients who come in 72 years old and they're not a marathon runner 72 years old. I don't biopsy them. You have to prove to me that you're really healthy 72 years old who's going to live till 87 for me to biopsy.
Why